Hello and welcome back. Thanks for joining us. It's Ben and Adila. Today on the show, we are joined by a doctor who also works on some cardiac CT imaging on patients with genetic cholesterol abnormalities.
We ask the hard questions, find out what started his amazing career, what is required, and some of the interesting stories that come with this responsibility. Please welcome Dr. Biyanka.
Thank you very much for that very warm introduction, and I'm also one of your biggest fans of your podcast.
I know,
so I'm very glad to be on.
We definitely had to have you on, so we were very excited. This is an honour for us.
An honour for me too.
So Biyanka, can you tell us a bit about your journey? So going through undergraduate and going into medicine post-grad, how many years of uni does it take to get this far to where you are today?
Yeah, look, so quite interesting. So when I did medicine, I did medicine at UWA, or University of Western Australia. And so when I got in, it was in 2009 and I started in 2010. So I went immediately from high school. So it was actually an undergraduate course at that time. Though things have changed now. And so at the time I got in from high school and did 6 years of undergraduate medicine at UWA, and then graduated in 2015. So it's a bit of a long process, 6 years, and it is a bit daunting, I guess, looking back, that you go straight from being 17 and going into a medical degree at that point where you are quite young and you don't really know exactly probably what you want. But I really enjoyed it.
Did a lot of your friends who started in the same cohort as you, did a lot of them stick around?
Yeah, they did. So it's, I think, even because the medical degree at UWA, the undergraduate course had been going for a long time, and so the dropout rate is very low, to be honest.
That's interesting, because I'm thinking when you're 16, 17, 18, coming out of high school and you think you want to do medicine and be a doctor, how many people actually
stick with it?
I find that so interesting.
I think, you're right. I think there's two ways you can think of it. So I think people get into medicine, they work really, really hard to get into it. And so
it's not a decision you make lightly.
Correct. So and so people generally understand that it's a kind of a large commitment in your life that you're going to be making by choosing that career. And so when people do get selected for medicine, it's likely that I think people are trying to persevere through any difficulties that they might run into to try and finish the degree, knowing that things probably may become more interesting, or they might get through the tough patch that they're getting through and really enjoy their career still. So from what I understand, the actual dropout rate is actually very low.
Well, that's amazing to hear.
Yeah.
That's 6 years that you go through as well, studying medicine. That's a mixture of coursework as well as some placement.
Yeah, that's right. That's right. So the way it used to be broken up was first 3 years were all kind of lectures and labs and things like that, which are very similar to other science courses and things like that. While the last 3 years were more clinical based, and so. Pretty much we didn't see our friends that were doing other courses anymore because we were always at hospitals, so we were usually doing rotations at the major hospitals around WA. So at that time was Fremantle Hospital, Royal Perth Hospital and Charles Gardner. Usually we would rotate through those and do our different rotations. The first year is mainly like trying to understand what the body, basic anatomy and basic physiology. And then second year is kind of consolidating that in more detail. While third year they used to say, now you've learned what the normal body is. Now in third year you kind of learn what happens when things go wrong, and so you learn about pathophysiology when things of different diseases and all the rest of it. And then in 4, 5, 6, like I said, you consolidate that with your clinical knowledge and seeing real patients, and also learning examination techniques and how to take histories and things from patients.
Wow.
Right.
That sounds so exciting.
That's
full on. Oh, right.
Full on and exciting.
I remember when I was at uni, I did like a human biology degree, so we did a lot of anatomy and physiology as well. I went to UWA for an excursion. We went to CTEC.
Oh, yeah.
At UWA. I'm not sure in any of your years of studying did you ever use those facilities. So what we actually went there for was we wanted to practice I don't know if it's mostly for surgery training. They had you know, when you put
Suturing?
laparoscopy, suturing, that kind of stuff.
Yeah,
So
yeah.
we kind of had to go
Uh-huh.
using sponges and suturing
Yeah.
with stitches, or and then, you know, when you have that camera inside someone's body.
Yeah.
Feel free to help me out anytime with
So I
what's
think
that
our
called?
laparoscopic procedures with the
knew
cameras that you put
And it
inside
was actually really tough to.
to navigate.
Were you ever involved in any of the things?
So I think the first time I ever used a laparoscopic camera was when I was inside a patient doing an appendicectomy.
Don't tell the listeners that.
But like I was there with, you know, a
Somebody
senior
to-
surgeon and everything, and so they were kind of helping me navigate. But they often said that often the students are better than them because they like play computer games and stuff like that, so they're able to navigate and do that kind of thing
Interesting.
quite well.
Transferable motor skills.
Correct. So, which is quite good. But in terms of CTEC, I did the same things as you in CTEC,
Oh, no way.
just in a medical degree. So I learned my suturing there. Sometimes we have different kinds of. We didn't really have our. Because we learn anatomy sometimes from cadavers as well. Cadavers, they were actually just kind of next door. There's a separate area that's quite close by that we learned them. But yeah, suturing and all those kind of
I think
skills
there were
that we
also
learned in
some
CTEC.
dental students who were
Oh, yeah.
using the room at the same time, so it was kind of towards the back benches, and they actually had like pig's heads, I think, and they were
Oh,
doing dental work, practicing with like.
Oh wow!
Yeah.
Like the whole pig's head,
No,
or
just-
just like the
Do
mouth.
pigs even have teeth?
They do. Their teeth are actually very similar to human teeth, aren't they?
Oh, I don't know.
Yeah, I think they were
don't know much about
practicing on
pigs.
pig's teeth, and we were just like, oh my god, like, what is happening? But it was really interesting.
Out of my scope, I think.
No.
That was interesting.
So I think CTEC actually stands for Clinical Technique
God.
Education or something.
I used to remember, but
It's
I
like
can't remember
doctor
anymore.
training.
Yeah.
Anyway, sorry about the sidetrack. So you talked us through a little bit about how you did medicine during an undergrad. It took you 6 years, and now it's actually a postgrad at UWA. So that means you actually had to do 3 or 4 years of a different undergrad before
Yeah.
you then went into medicine.
Yeah.
What are your thoughts on doing it that way?
There are advantages and disadvantages. I think.
Maturity?
Sorry. Yes,
There's a lot
maturity.
more.
Yeah, 100%. I think that's one of the advantages, and you're probably more likely to get people that truly want to do the degree getting into the course because they're a bit older. They understand a bit more about the world and what they maybe want to do in the future. One of the things that's difficult though is that in WA you still have undergraduate courses, so you still have.
There's
for
one
example,
at Curtin now?
Correct. Curtin has
There's only a few years in the running.
Yeah, so I think they're graduating their first students this year in 2021, so to start working in 2022. So it's a relatively new course, but there is an undergraduate course, and so I think one of the things is that given that not all the courses are postgraduate, that people that want to actually do it straight away still have that option to do it. It does mean that there are, I guess, different options for people, which is good, but there are some cons in that now you're cramming a medical degree that I did in 6 years into 4 years at UWA. And that means that often the students now, they get less holidays than we did as a result to try and cram that in. But it also just means that you can't fit that level of clinical exposure that we got during our training.
That's right, you had
in
3
4
whole
years.
years. Yeah.
Correct, 3 whole years of clinical, while they kind of have 2.5-ish, I think, from my understanding. But it's a lot more cramped trying to get all that information in, but probably doesn't seem like the best way. But that being said, some of the people that I'm working with now have come out of that course and they're fine. Yeah.
Definitely, talking about cramming that much into a shorter span of time. I mean, I can just imagine how stressful that would be, just trying to remember, keep up with everything. Though I guess as well, if you decide to go on that path, choosing the right undergraduate course, so if you choose something in human biology or something like that, it would probably benefit in taking some of that stress off, but I still see the downside in that clinical exposure.
100%, and but you'd be surprised by how many people that go into medicine have never done anything related to medicine prior. I think it would be very similar to how I felt when I first started, like my first few weeks of doing medicine. I'd never done human biology. I'd never
Not
done
even in high school.
Not in high school. So I did like chemistry and physics for my sciences. So I didn't do anything with human biology. I roughly knew there was 2 kidneys. I didn't quite know where the liver was.
Oh, wow.
They used to do this quite cool thing in in UWA, which was first day or first week, you would have a chart of a human body, like a diagram. You have to label where you thought the organs were, and then they give you that same diagram when you graduate at the end, so you can see how far you kind of come. Because sometimes you feel like you haven't really progressed that much, but then you look back and you're like, oh, okay, I do actually know a little bit more than I did before.
That's amazing. I love that.
I know where the liver is now.
Yes.
I hope you do. So, Biyanka, taking a step back, can you tell us about how this all started? What made you want to become a doctor?
So, as I mentioned before, so I did like physics and chemistry and in high school, and I really enjoyed my sciences. My family mainly engineers. And I did like my mathematics as well, and as you guys probably know, I haven't heard, I really like cars, and I'm interested in those kind of things. But I think seeing my family work in engineering, and it was a very desk job kind of thing, and I probably didn't want that. I liked interacting with people, and I liked the idea of being mobile during the day and being involved in different things, and I found the idea of doing medicine from that point of view quite interesting. But obviously, I probably thought that I wanted to do it when I was probably about 15. And then I think knowing that I wanted to do that really pushed me to work hard in high school, because I knew that, there's no particular mark to get into medicine. It's always changing, and it's a combination of things to get into medicine. So it's a combination of your school mark, your interview, and a aptitude kind of testing, which is called the UMAT. And things have changed slightly since back when I did it, but similar kind of process. And so there's no specific mark, and so you just got to do as best as you can. And so that kind of pushed me to work hard. But in terms of there was no single moment or thing that made me kind of decide that. But it was kind of me thinking about probably not wanting to do a desk job, but still wanted to be something very sciencey.
If you didn't become a doctor, what would plan B have been?
You just read my mind.
Probably an NBA player or no. Look, I do like my basketball as well, but look, I don't have the height for that or the genetics. But
Bet for yourself.
Yeah, 100%. It's the subcontinental genes. There's nothing I can do about that. But look, I think if I didn't do that, I probably would do engineering.
Follow in your family's footsteps.
Yeah, but I think I would work in quite different areas to what they did. So I've got a brother that's an electrical engineer. I've got my dad who's a chemical engineer. But I probably wouldn't work in those fields. I think I'd go much into
mechatronics or mechanical.
Potentially mechanical, or even because I like cars, and in particular I like Formula One, which is my favorite sport to watch. So something to do with aerodynamics and aeronautical would be very cool as well, to learn more about that. But I'm pretty happy with that I still didn't choose that, because that's kind of like my hobby now, which is very different to what I do at work.
You probably would look at your hobby a lot differently if you had to do it
100%,
5 days a week.
It's good though, because you have such varied interests, in all aspects.
Yeah. Looking back though, it's been quite a journey to get you to where you are now. I'm just asking you a question. So, what does education mean to you? I mean, you've
been through it all, yeah.
Oh, I don't think I've been through it all.
Being a doctor is like continual lifelong learning as well. Like, it doesn't really stop, does it?
Yeah. Well, I think education's, as pretty much all of you guys would agree, is super important. I think it's almost like a basic need. I think that everyone should have access to, and unfortunately, that's not true. But it should be, and I think it provides a base level of. Education provides a base level of background to people, so that they are able to, progress later on in life, and gives them the opportunities to, work in areas that they're interested in, to discover things to help humankind all over the world, and to really progress us and help people all around the world, to either live longer, live better, whatever it is. So I think education's it's such a big question to ask, but I think hopefully that sums it up a little bit.
Yeah, as you were saying your answer, I was thinking about, in this remote part of the world where they have no access to schools, education, internet, there are young children and, girls and boys who maybe have such bright ideas, but they were never given the opportunity to explore that and be able to, dig into that
100%.
potential. So can you think how many wasted
Definitely. How many
Like-
wasted ideas have suffered because of inaccessibility
Yeah,
to information
100%.
and
That's
technology? I
crazy.
mean, I think that the
There's still
internet
a
has
lot
really
more
opened it
to
up for a lot of
Yeah,
people.
yeah.
A lot of people making
Yeah,
apps
I'm sure there's
and
not a lot of
contributing to
places
research.
with no internet, right?
Yeah, I think just really remote places probably wouldn't still have internet. But your story just reminded me of something, which is of there's a famous mathematician who grew up in India. His name was, I think, Ramanandran or Ramachandran or
Was a
something like that.
mathematician?
Yeah, mathematician.
Mhm.
That
And
rings
so
a bell, I can't-
yeah, so it was
Yeah.
about 100, like I think it was born like 100 years ago or something like that. And he had no formal schooling, as far as I'm aware, and he taught himself mathematics. And he actually solved theorems that no one else in the world could solve.
Really?
And then he became the first professor of mathematics at Oxford, I think. And then he died very early. I think it was from like tuberculosis or something. He died only at the age of like 30 or something. But people are still looking through his journals, trying to find out things that he figured out, because all of them are coming true. Like all of them have been proven right slowly. And so I think just recently, like a few years ago, they found like a few extra pages of things, and they found a whole new theorem that no one had ever thought of.
Oh my
Wow.
god.
And
Such a
What a
brilliant
legacy.
mind.
100%, and he had no formal, education. Imagine all these other people that, maybe if just a little bit of education, they
You
could,
never
they could,
know
they could
what the
find all these
potential
things.
is.
Mm.
Crazy. All right, we'll take a short break, and after the interlude, we'll talk a little bit more about what it is like being a doctor.
Thank you for sharing that amazing journey through education with us, Biyanka. So, can you tell us a bit about what happens after you graduate? You finish your internship for your 3 years exposure and to become a full consultant. Is that right?
Yeah. So I'll sum it up. So basically, you do your 6 years, and then you graduate, and then following graduation, you are a doctor. But you do a period of 12 months, which is called your internship, where you have a provisional registration on the Australian licensing to work as a practitioner. And so you do 12 months of internship, which you do at usually at a major tertiary hospital.
Where was yours?
So Fiona Stanley was mine. So
I think they had just opened, right?
yeah, so it'd only been open for, we were the first set of interns to do the whole year at Fiona Stanley. The previous interns did their first few months at Fremantle, and then they did the remainder at Fiona Stanley.
That's
So-
better because you get both hospitals.
So like so
cute.
Fiona Stanley still is under the same group as Fremantle Hospital and Rockingham Hospital, so we moved between the three.
Between the three, anyway.
Correct, yeah.
And
So-
during your internship, you moved between the three?
Correct, and throughout your whole time that you work here.
Now, I don't know if you guys watch a lot of Grey's Anatomy or medical shows, but on shows like that, interns get treated like garbage. They
Yeah.
do the worst jobs. They get stuck with all the paperwork. Is that an accurate representation of your internship, Biyanka?
I haven't watched Grey's Anatomy, and I'm
What
very
about
proud of that.
House MD?
I'm sorry, we're going to stop this right now.
House is very good because you know that every diagnosis is lupus. But look, I think as an intern, you do a lot of the paperwork, unfortunately, but it's not all bad.
Do you get stuck with the really bad jobs?
Yeah, I guess so. Like it's going to be the more tedious things to do, like your paperwork and maybe.
This person just puked. Go clean that up.
Unfortunately, that's the nurse's job.
Oh.
So the interns probably wouldn't have to do that. But they do things. The interns do take blood. They put the cannulas and drips in. We say they're the worst jobs, but they're actually vital skills as well.
Fundamentals.
You do need to know them. And you actually learn quite a lot sometimes by doing the paperwork as well. You learn how the hospital works, which is important. And
You're so positive about it. I love that.
yeah, well, I think when you're doing it at the time, and you can either be negative about it and not enjoy it, or you can try to think about how it's going to help you in the future and how you can learn from it.
And most people are happy to help, or did you get one or two people who really looked down on you for being like an intern and new on the food chain kind of thing?
Not really. Like I think if you're an intern, then generally, like for example, if you're discussing a case with another doctor or another specialty and you're referring your patient, it's probably a good idea to always tell them that you're an intern, because people are always a bit more or tend to be a bit more gentle towards you, understanding that probably remembering what it was like for them as an intern.
All right, Biyanka, tell us about this interesting case that actually happened here at our hospital.
Yeah, so there was an interesting one, which was I thought just a very cool case, and so did other people, I guess, because this case that happened at Fiona Stanley and happened local to WA was actually published in the New England Journal of Medicine, which is the most significant, most prestigious journal in medicine in the world. And so there was a case of a nurse in a nursing station in a place called Coral Bay. And in this nursing station, it's just one nurse that stays there. And, they look after any patients that kind of come in. And if they need a doctor, they do a kind of telehealth kind of interaction with the doctor.
So they call like a Zoom meeting with the
kind
doctor?
of Zoom, yeah, correct. And then they can kind of discuss what's going on, and the doctor can kind of decide and help them with what needs to be done. So one day the nurse was there, and the nurse developed chest pain.
Oh.
And started to get the chest pain was getting quite bad, and so they did a ECG on themselves. And then did a telehealth appointment with an emergency doctor who found that the nurse themselves was having a STEMI.
Oh my
Oh
goodness.
my God.
And it was quite a big one as well. I think it was like the LAD, I think, off the top of my head. And so it's a big artery. And so they were having and I presume it was very, very painful. So as I mentioned before, there's no cath lab available in Coral Bay. So the treatment is?
The
Thrombolytic medicine drug.
Yes. And so there was no contraindications in this case. So, but you need to be able to give this. So the nurse self-cannulated themselves. So they put a needle into their own vein and put the cannula in, which is a plastic tube that stays in the vein, and self-thrombolized themselves. So gave the thrombolysis to themselves.
Superwoman. I mean, I'm assuming it's a woman. It could be a man.
I think it was a man.
Superman.
Yes, and then the emergency doctor on the other end organised a Royal Flying Doctor Service to come and get them. The patient was flown over to Coral Bay, from Coral Bay to here. The thrombolysis worked and reduced the chest pain, and was able to somewhat relieve the clot. They came here. The next day they had a coronary angiogram performed, which showed a severe narrowing in the area of the clot. Had a stent put in, and then got put on all the right medications, got the treatment, and made a very good recovery. And so that story was published.
My eyes are like wide, just in suspense, and I'm kind of like on the edge of my seat. Wow.
And it's always a very hard thing to cannulate,
especially when you're having that much chest pain.
When you're having that much pain.
Oh my God.
And to do it yourself is a fascinating case. And so it was published in the New England Journal of Medicine by my colleagues that work here at Fiona Stanley.
Wow.
Oh
It's a fascinating case, yeah.
That is really interesting.
Yeah.
Don't know what I would do in that situation.
So a bit more, maybe a good story, a good outcome compared to the other stories that we talked about.
Yeah.
I'm sure you have a lot of other stories to share, but we might have to try and wrap up. And, obviously in the future, if you want to come back and talk about some of those, you can definitely have your own little case study 2.0 episode. We'll chat a little bit more about your research before we wrap up, though. Could you tell us a little bit more about what kind of research you're involved in and how you got into it?
Yeah, so my interest, as you can probably tell by some of the stories that I've told, is in cardiology, and so the research I'm doing is obviously in that field. More recently, my main projects have been involved in cardiac imaging, specifically cardiac CT. So as I mentioned before, people do coronary angiograms, which is where they put a tube into your femoral artery, which is the artery in your groin or the artery in your wrist, and they pass up a wire into your heart, and they release dye into the arteries, and they use x-rays, and the dye flows through the arteries, and you can determine where people have narrowings and things. But obviously that's quite an invasive procedure, so someone decided that maybe we could do this with CT, and so they do a CT scan. They give contrast through your vein, and they time it such that they take the scan as the dye is flowing through your coronary arteries, and therefore you get the same idea. You can identify areas of narrowings, and also identify areas of plaque and further information about your coronary arteries. And so my research is looking at CT coronary angiogram in patients with genetic cholesterol abnormalities, and so we call these patients familial hypercholesterolemia. And people think of this as being a very rare condition, but actually 1 in 200 people have this. It's a very underdiagnosed, and people that have it can have almost a 90-fold increase in cardiac death. And so it's very important to treat them effectively. And so I'm looking at advanced plaque characteristics to predict myocardial infarction and adverse cardiac outcomes in this patient base of really high-risk people. It's never been looked at before. These techniques have been proven in general patients, but they've never been looked at in these patients who have these abnormalities, which is very interesting.
And you published a few papers. Was that on this particular research?
No. So some of them have been on a few other things. So I've done one earlier this year, which was on cardiac imaging and blood biomarkers. So what we call so you can take blood tests that can tell us a little bit of information about the heart, and there's some things on imaging. So in cardiology, we have imaging in terms of echocardiogram, which is an ultrasound of your heart, and also on CT and also on MRI. And so I did a review paper on that, which has been still in print at the moment, so it should be out shortly.
Super exciting though.
Yeah, very exciting. Then I also did one on Q fever endocarditis. So Q fever is a very rare is a rare infection that was actually discovered in Australia in early 1900s. They basically it comes from usually farmers usually get it, and they get it from animals. It's an infection you get from animals. There was a group of abattoir workers in Queensland, and they had this fever, and no one could figure out why they had a fever. And so the doctors at the time labelled them with query fever, and the name Q fever came from that.
Right.
Yeah.
Can you get that today?
You can get that today, and generally still it's farmers and people that have contact with animals that get these conditions.
Not cats though, right?
Not cats. But cats can give other diseases.
Sort of thing. Let's not go there.
So I looked at people that get Q fever, but then they get infection of their valves. And the valves can be very difficult to diagnose for a number of reasons for this type of infection. And so I did a review of all the cases ever published in the world, plus our own from WA that have never been published before.
Wow.
And I think it was about 185 cases. And so that's the largest collection of Q fever endocarditis ever described. So that was quite cool.
Good work.
And then I had another one which was looking at again, cardiac CT. And so I was looking at, so generally when we start cholesterol tablets and things, we look at people's age, if they smoke, their blood pressure, what their cholesterol levels are, and then we calculate a risk score, and then we start therapy. But I looked at maybe how good that was compared to maybe just using CT to determine, because if, you can talk all you want about risk scores, but, that can't beat looking at the actual coronary arteries. At least that's the hypothesis, and so we wrote a paper about that, which has also been submitted for publication. That's not been accepted yet. And then I did get one which was editorial on.
So that's 4 so far? Just in the last year or so?
I think that's 4.
Amazing.
Yeah, I remember. Yeah, then it's editorial.
This is what happens, Ben, when you don't have 3-hour lunch breaks, right?
What's a 3-hour lunch break?
We need to learn from Biyanka.
Yeah. So the latest one was an editorial which has been published in JACC Imaging, which is a big cardiology American journal, and that was on. It was an editorial on a paper that described a very advanced AI-based statistical method to describe people's coronary plaque. It was quite a niche subject, and but it was a good opportunity to write an editorial. So
Yeah,
that went well.
definitely. Got to take every opportunity you get.
Definitely.
Absolutely.
That's a lot of research output there, and you're juggling clinical stuff as well.
Yeah. So
How do you balance it all?
yeah. So I think it's been.
Or even how do you keep it separate as well? Because there's a lot of overlap there.
There is, and so I've been very fortunate in the last 12 months that, as you guys know, that I've had a fellowship. So in WA, we had this thing called a Registrar Research Fellowship. As I mentioned before, I'm a registrar. And so people could apply for this fellowship. They give out usually like 4 or 5 of these around the state. Basically it allows you to work half-time in the clinical field, but half-time in the research field and still get paid to do so. So it allows you to do that. And so that's what I was awarded, and so that's my time's coming to an end now. So this is my last week of the 12 months. I know, but I'll still be around. I won't disappear.
Yeah.
And so that has allowed me to really, work with to cover a lot of different ground, in all the research that I've done this year. So it's allowed me to do
it definitely sounds like you made the most of this last 12 months, so
yeah,
it sounds like you've done a lot.
It's been really good. I haven't quite finished everything yet. My main study still has a few things, and we're hoping to do 3 papers from that, so so that'd be very cool.
So you'll probably work on that even after your fellowship is over.
Definitely.
Just to try and tie it up.
Yeah. So I think you asked about how you get involved in research and things as a doctor. So I only got this fellowship because I'd done things before. So generally the way it works is you work in the hospital, you work your full-time job there, and then research is something that you do in your free time to try and one, learn more about the area of your interest, and 2, also to gain a better understanding of how research happens, and it helps you understand other people's research as well better. So when you're reading trials and the latest COVID research, for example, or whatever, you understand a lot better because you understand how research works. And then 3 is also it's a great way of differentiating yourself from other people that are or maybe also competing for something that a job that you want, or a training program that you want. And so for these reasons, you kind of get involved in it. And I did that when I was starting from when I was an intern, and kind of progressed, and then I met our supervisor, who's the same for all of us, Prof. Devetti.
It all comes back to Girish.
Yeah, it does, and he's amazing, and so through him, I've been able to really get my research going and get this opportunity, this fellowship, which has allowed me to do even more.
It sounds like you've had a real thirst for research from the get-go. Would you say you enjoy the clinical side more, the research side, or would you say that in the future you may, I don't know, perhaps
do a PhD, be a doctor?
I think it's very hard. They're very different. They're very different, but I think it's almost best to have a bit of both. If you have a bit of both, it makes you, being a good clinician, makes you become a better researcher, and becoming a good researcher makes you a better clinician, because they're very intertwined. And I feel like
sort of feed to each other.
They do, and I think it would be very hard to be a great clinician without having some kind of research background.
Both of us agreeing as well.
yeah. It's true though, and I think when I first started doing research, I found it difficult. Because maybe my supervisors weren't always the best. And I think I've seen in your previous podcast, people talk about the difficulties they had with different supervisors and things like that. For me, it was not that I didn't get on with my supervisors or anything like that, but sometimes the supervisors that you have actually lack a bit of experience in research themselves, and they may not know the direction to take things. As when you compare to Girish, our current supervisor, he feels like he's always been doing a research paper since he was born, like this isn't an athlete, so he knows.
He's always got ideas, and there's always something to do.
100%. He knows how to twist something into something that's publishable. He knows how to make something interesting. He knows what are the hot topics in a certain area, and when you have and he's so passionate about it, and he's so excited all the time about it. It's hard not to yourself, and feel the same way.
Makes me tired.
So
how he does it,
so he's definitely very motivating, and so I think he's a big factor in why I've become more and more interested in it, and I'm really enjoying it.
Definitely. And on that note as well, like in terms of your career trajectory, or even in your personal life, do you have any goals for this year, or even as you move on into the next few years? Where would you like to be? What's there to do and achieve?
Yeah, so I think I mentioned before, I'm in physician training, so I'm at the very end of my physician training now. So I have my exam there's a written exam and a clinical exam, and so the written exam is in a few weeks' time, and then the clinical exam will be later on in this year, assuming I pass my written. And that's kind of like the last exam I kind of have to do for my medical career. So it's a big exam, and so I'm really just hoping to get through those. That'd be fantastic if I can.
No, I'm sure you will,
Yeah.
because I think you've studied every day for the last year or so,
Yeah.
or even two. So
Yeah. So so when I'm not doing my research or not doing my clinical job, I've just been studying this last 12 months or so. So it's been I'm looking forward to getting through that, and
gonna have a big celebration when it's over.
yeah. Well, I think Girish wants me to write these papers, so I think we're going to do that.
Oh man,
Do that
So-
with a piece of cake or something.
yeah.
no rest for the wicked.
No, but
What about any personal goals?
yeah. Look, I think one thing is like I wouldn't have been able to do what I've been able to accomplish. I wouldn't have been able to accomplish what I have already without my wife and my family and my friends as well. They've been very supportive to let me do that.
Sounds like a little acceptance speech. I'd like to thank you.
No, but it's true. I wouldn't have been able to do it without them.
Just
and,
a little shout out. No, of course.
and then and also especially with like my friends who I've probably ignored largely for the last 12 months while I've been studying as well. So I haven't been able to. Often they'll message me to catch up. Sometimes they'll say dinner Thursday, and I'll get studying. Sorry, I can't make it. But it's nice that they still ask, and so then I can try come. But it'd be nice to be able to spend more time with them as well.
Which
hopefully.
you'll be able to after this video.
Yeah, hopefully if I pass.
Can slowly reconnect.
Yeah. So it's good. Luckily we have Facebook and WhatsApp and all that stuff, so
Yeah.
it's not too hard to talk to people
Stay
anyway.
in touch. Yeah,
Yeah.
definitely.
But otherwise, yeah. So our goal would be to finish my exams, and then assuming I pass, then apply for cardiology training and hopefully get in at some point.
Amazing. You can help me recruit patients in the CCU.
That's right.
I need someone on the inside. On that note, Biyanka, thank you so much for joining us and sharing your very interesting journey. It's given me a real appreciation of how hard doctors really have to work. I mean, I know they're constantly working and busy and things like that. But yeah, definitely great to hear.
Definitely, it's given us a great insight into what's required to get to where you are, and what a day in the life is for. I'm sure. Well, I've been wondering, but that is quite a hectic day. You have to deal with every day.
Yeah, and all the best with the exam. And
Yes.
thank you so much for making time to come on the show.
No worries.
It's great to finally have our biggest fan on. So
Yeah.
you listen to like every episode. So
Yeah,
as soon as it
100%.
drops, 10 o'clock on a Wednesday, like, I'm listening to it, guys.
No worries, and thanks so much for having me, and really enjoyed it, and I think I'm back again for another one later on, so
Yeah,
that'll be
definitely.
good fun.
Cool, thank you. And thank you everyone for listening. We'll see you guys next week on
On Wednesday.
scratch that. We'll see you guys next week. Thank you so much for listening.
Don't forget to like and subscribe.
Yeah, practicing for your medical blog already.
Yeah, that's right.
Love it. All right, guys. Thank you.
Yeah.
Bye.
Bye.